Dear friends, dear colleagues, good morning from Thessaloniki, Greece. I am Kleanthis Manolakis, and the topic of today's presentation will be about the new generation of Zirconia. I'm very happy and very excited to be able to share one of my favorite topics with you, and I would like also to thank Aidite for providing this opportunity. I hope you will enjoy my presentation. It is a recorded presentation. But I'm a late night guy anyway. I like late night talks, so it's past midnight, and I hope you will enjoy this presentation. Basically, we deal about reproducible and safe clinical concepts in contemporary restorative dentistry. So I have been practicing clinical dentistry for over 25, 27 years, and usually longevity is what is essential for us clinicians and for our patients. I would like to use the foreword by Professor Morton Parel in this famous book conducted by Kalmish back in 2005. And in the foreword, Professor Parel explains this dilemma. So the fixation of those as clinicians who learn and practice implant dentistry, usually the surgery and the cosmetics. These two aspects are navigating our surgical results. But what drives actually the engine, which means what keeps our restorations going for years and years? So structured initial planning that will result in a viable implant-supported prosthesis, and the intrinsic and extrinsic designs of that customized prosthesis underlie, underscore, and even supersede the drama of surgery and the thrill of cosmetics. So it's not only about surgery and not only about cosmetics, but it's about advanced surgical and restorative concepts that we need to apply in order to have reproducible long-term results. So essentially, our clinical mission is to inform our patients, to protect and to restore. Restore missing teeth, restore gaps. Is it only about restoring gaps? Actually not. It's about restoring self-confidence and function. So this is our main goal in restorative dentistry. In that sense, we are in a perpetual search of a unique dental material that would combine strength and aesthetics in the same fashion. Now, the first chapter is about performance of zirconia versus porcelain fused metal and other restorative materials in implants and teeth. What is the best prosthetic material for implant restorations? This seems like a simple question. We all have our preferences, and obviously there are many choices. Material. Each one will have an effect on the clinical outcome. Essentially, the qualities and effectiveness of a novel restorative material may not be determined until long after it has reached the market and it has given clinicians and researchers an opportunity to test it and try it out. In that sense, prolonged observation period is definitely essential. I would like to start with some subgingival materials that are available for restorative purposes at the moment. This entity focuses on the materials that will be submerged after seating the restoration on an implant, and in that sense the consideration of tissue biology is essential. The adherence zone is the soft tissue area that is in contact and interaction with the restoration, and this is a different zone than the requirement of the material that is exposed in the oral cavity. Now, one important question is which material can increase the adherence zone, thus increasing the bony crest protection? Some materials do tend to develop stronger adhesion than others to periimplant tissues. Is this correct? Now, implants can be restored with a wide variety of restorative materials. Some of them are zirconia, titanium, lithium disilicate, veneering ceramics, polyether ether ketone, this is PEEK, that we use in our office regularly, and again metal, gold, and other materials. Let's start with gold. So we're considered a state-of-the-art solution for customized prosthetic applications. However, the use of gold has decreased due to lack of biocompatibility and high costs. Peri-implant soft tissue obviously do not form a sufficient seal with gold abutments, according to this experimental study in dogs by Abramson and a group of Göteborg, and they proved that soft tissue recession and crestal bone loss can be expected when you use gold abutments. In addition, long-term clinical experience shows that gold tends to corrode and undergo surface changes, according to the results of this study, when it is exposed to peri-implant tissue and body liquids for an extended period of time. So gold should not be recommended as a suitable subgingival restorative material. The next material that I would like to share with you and its performance is composite. So composite resin abutments have been suggested as an alternative way to restore dental implants. In vitro tests, the group of Pascal Magne and Urs Belzer from Geneva published their results in 2011. In vitro tests proved that composite resin abutments are as strong as zirconia ones. However, a major concern is the reaction of peri-implant soft tissue to composite. Why is that? Composite resin surfaces harbor plaque accumulation and they produce increased mucosal inflammation in many cases compared to titanium. Group of these results back in 2013. The use of composite resin abutments remains limited. They are not biocompatible in the long term. The next group that we would like to investigate is about veneering ceramics. Veneering ceramics cannot actually form a stable junction with peri-implant soft tissue and should be avoided in subgingival positions, according to Abramson and a group from Göteborg. Why? The study they conducted showed that dental porcelain appeared not to be a proper material to establish reliable soft tissue adherence. The outcome with feldspathic porcelain was the least favorable because the extent of soft tissue recession and bone loss was the highest with this material, in this material group. This fact is attributed to surface roughness. Veneering ceramics have been shown to be the roughest prosthetic materials used subgingivally. Veneering ceramics also lack the ability of zirconia to preclude the adhesion of bacteria. So in terms of bacterial accumulation, zirconia performs better than veneering ceramics. A modern material that we increasingly use more and more in our daily routine is lithium disilicate. Lithium disilicate has recently become the choice of many clinicians, and this material offers increased strength of 400 megapascal to withstand occlusal loads and can be used in advanced digital workflows. Studies suggest that lithium disilicate materials are not biologically inert and are more cytotoxic compared with composite or that published their results already back in 2003-2008. Obviously, lithium disilicate lacks the biocompatibility of zirconia, and zirconia in that sense is likely a better option for subgingival positioning based on a number of studies highlighting its biological qualities. So, zirconia is biologically better than lithium disilicate. Still, in case we want to use lithium disilicate in the submerged zone, should we glaze or polish its subgingival part? Essentially, by removing the glaze and exposing the polished, denser and smoother lithium disilicate surface increases its biocompatibility. So we don't like glazed lithium disilicate in the submerged zone. So conclusions for the subgingival materials that can be used in restorative dentistry is that zirconia obviously is the best material for subgingival restorations because of its surface quality and the least bacterial attraction. It is simply not sexy for bacteria to adhere on zirconia. Second conclusion is that zirconia is the most biocompatible material available now, and it is followed by titanium, then polished lithium disilicate, and finally veneering ceramics as the least biocompatible option. I think this is a powerful message in terms of how to deal the subgingival, the submerged area for implant-supported restorations. Let's move on to the supragingival materials, which is a different category, or we use different criteria to discuss about the supragingival restorative material available. In this category, the best response from periimplantitis subgingival tissues. Okay, so subgingivally, zirconia is the best material available. However, aesthetics are very important for the patient and the clinician to evaluate. So, from the patient's point of view, the choice of supragingival material in terms of function and aesthetics provided is much more important than subgingival biocompatibility issues. Now, for the category, we can restore implants using several restorative materials. For example, feldspathic ceramics on zirconia or metal framework. We can use monolithic lithium disilicate restorations, or we can use monolithic, which is also called anatomical zirconia restorations. This is actually the three groups that we would like to focus in this presentation. Now, for many years, the standard of care was feldspathic ceramic veneering. Porcelain fused to metal possesses optimal aesthetic outcomes, but is a relatively weak material which displays up to 100 megapascal, actually not more. On the contrary, zirconia provides strong, biocompatible, and aesthetic outcome in tooth and implant-supported restorations. In this way, it creates an obvious advantage over porcelain fused to metal restorations. In that sense, the use of zirconia, of course, for prosthodontic rehabilitation has become an everyday practice in dentistry. So this segment is expanding more and more. Medium and short-term studies, unfortunately, we don't have long-term studies on zirconia applications, but this category of medium and short-term studies have shown that zirconia dioxide ceramics, specifically yttria tetragonal zirconia polycrystal as a core material, has considerable advantages over other framework materials. And it could be considered for usage in any region of the mouth. So the posterior and the anterior area of the mouth can be restored with zirconia. And I will share some clinical cases with you, both in posterior and anterior areas of the mouth. Unfortunately, though, the adhesion of dental porcelain to zirconia is apparently not sufficiently strong to withstand occlusal forces without the lamination or chipping. Within 5 years of observation period, chipping or extended fracture of veneering material can be expected to show in 6 and up to 22% of clinical cases according to these studies. This is one of my cases, so we were very proud to deliver this implant-supported veneered restoration in March 2015, and a few months later we already observed a little chipping on the canine. Is this frustrating? It is definitely frustrating for the patient and also for the clinician. Now, according to the study by Heinze that was published in 2010, 10% of zirconia fixed partial dentures versus only 3% of metal ceramic fixed partial dentures had to be replaced over a 3-year period because of veneer chipping. So more zirconia than porcelain fused to metal had to be replaced. According to the literature, the bond of ceramics to metal is twice as strong as the bond of ceramics to zirconia. Additionally, the veneering ceramic material for zirconia is weaker per definition than that used for metal. So this is the next step in terms of dealing with the chipping of the veneering material. In that sense, monolithic zirconia entered the implant market as a restorative option because of the complications with ceramic chipping that we all clinicians observe occasionally. So monolithic zirconia restorations have no veneering. The entire restoration is made exclusively from zirconia. The monolithic zirconia is especially indicated in implant-to-implant occlusal situations. These are cases where the entire occlusal load is applied to implants and occlusion is stable, according to the study by Professor Linkevicius, published in 2019 by Quintessence. This is an exceptionally useful book for the clinician. So primary application of monolithic zirconia restorations are posterior implant-to-implant occlusion. My last case will deal with this clinical situation. So there has been an evolution of modern monolithic zirconia, and our favorite material in our dental office is the 3D PRO by Aidite. We will talk extensively, and I will show you cases extensively about the clinical applications of this specific zirconia category. So the Yttria TZP has been used for all ceramic fixed dental prostheses since the mid-90s, so it's not a very new material. We have enough experience with the TZP already on the market. One of my cases back in 2019, we have been using in our office zirconia for over 10 or 12 years, I think. Optical properties of the first generation of zirconia were like the clinical single case you see on the left side of the slide. So it has a light scattering property which is pretty high. In that sense, our restorations appear almost opaque. They most of the time they need to be covered with a veneering material in order to give aesthetic outcome. Now, in recent years, we have the development of monolithic translucent zirconia dioxide restorations that do not require veneering ceramics, and we use them regularly. In that sense, for supragingival materials, conclusions are that zirconia frameworks veneered with feldspathic ceramics occasionally cannot withstand, unfortunately, the occlusal forces in the posterior region due to weak adhesion and ceramics infirmity. Also, the fourth generation natural transition zirconia without layers, only staining, provides highly transparent incisal part and can generate exceptional aesthetic and functional outcomes. Now let's move to the clinical cases, which is, I think, more important for all of us. So I would like to share with you a few cases that deal with restoration of natural teeth. This young patient was not interested in doing orthodontics. He presented with extensive fractures of his anterior region, and by using 3D PRO in these 2 units, 1 unit on the left side, 1 unit on the right side, we can restore the aesthetic zone. This is the before and the after pictures. Of course, the prerequisite in cases like this is a skilled technician. We are very privileged and very happy to have a skilled technician. His name is Diamantis Tsifoutakos. He is also located in Thessaloniki, and he is a very skilled technician. He's also very talented. I will show you more of his work later on. This is another indication, a Maryland type full contour zirconia restoration of a fairly young patient, 40 years old, missing a canine on the upper right side. He doesn't want to place an implant. He would favor a more conservative restoration. So in this case, we can produce a Maryland type bridge that is cemented with MDP containing resin. We have enough literature over 10-12 years. The longevity of this type of zirconia cemented with MDP composite, lutein composite, is exceptionally well. One extensive case involves the whole upper segment. So we want to replace this bit old-fashioned metal acrylic bridge with cross arch full contour zirconia bridge. That is also we also used 3D Pro in this case, and so can face this challenging clinical situation. Now I would like to move on with just one case on single implants. We have many cases on single implants, but I chose this one. We used an older type of zirconia, less translucent that we would use today, but with an exceptional longevity, 7-year follow-up. It's a beautiful restoration that withstands the time without any chipping or without any kind of controversy. I would like to continue with some clinical cases on fixed partial dentures. This is the baseline of a case that we started dealing with back in 2014. A patient that has been in our office for many years. For some reason, probably neglect or not so good cleansability, we are facing some unsalvageable pontics. And this case was restored with a couple of implants. In the anterior area, it was a guided surgery case. This is the framework try-in, and the final restoration is a zirconia layered bridge, 4-unit bridge that is screw retained. Our standard technique is screw retained restorations. We don't use cement retained restorations, and we try to avoid cement retained restorations as far as possible because of the issues that are dealing with retrievability. We always want to have access to the implant abutment interface. So this is the zirconia layered bridge in situ, screw retained, and this is the final outcome done by Mr. Tsifoutakos, a very skilled layering of ceramics, and this is the 5-year follow-up, and she's probably as happy as during her wedding, I would say. At least she's smiling and she's feeling self-confidence for this restoration. So zirconia, we have an clinical experience of zirconia over 10 years, and their performance is exceptional. Although, as you can see on the right side, we had quite unfavorable restorative baseline in this specific case. I would like to continue with the second case, which involves also a replacement of missing teeth in the aesthetic zone. And in this case, we used Zirconia monolithic, and it was also an immediate loading case. 1-year follow-up. This is a case that we used also 3D Pros, where 3 implants are placed in the upper jaw and 2 implants are placed in the lower jaw. We use the cut design and milling in this case, and these are the final restorations. So this is the upper, full contour zirconia, fixed partial denture finalized. This is the final outcome for the upper jaw, and this is in situ, the upper bridge placed on the implants, and this is again the lower, full contour zirconia. So there is no layering, it's just staining in this specific case, and I'm always amazed on how beautiful the aesthetic outcome is in this monolithic zirconia that is the 3D Pro. This is the lower full contour zirconia bridge finalized, and this is the 1 year follow-up of this case. We can observe optimal material stability and also optimal function, optimal aesthetic outcomes. So I believe that monolithic, 4th generation monolithic zirconia, and especially 3D Pro, is a very powerful tool in order also to create bond with our patients. Okay, so this is what we need. We need a happy patient, and we need to feel confident that we provide proper aesthetic and functional outcome. This is one of our more recent cases. It's only 6-month follow-up. Again, aesthetic zone, lower jaw, zirconia monolithic, delayed loading. It was a mess. Many teeth were fractured, some roots that had to be removed. 4 implants were placed in the extraction sockets, and this is the final restoration. Again, a screw retained, a monolithic, full contour zirconia, that bridge restoration that was produced by using the 3D Pro. There is no layering in this case, only staining and polishing. I believe that the aesthetic outcomes can be very exceptional also in demanding cases like this specific one. Our patient, she's a female patient, the age of 50. She's cleaning properly. We have enough attached gingiva, not too much in this specific case, but it is sufficient to produce this pleasing final outcome, which is also, in terms of aesthetics and functions, exceptional. Next case is again an older patient in the age of 70. It took him about 10 or 15 years to decide. It's almost a terminal dentition. You can imagine that only few teeth in the upper jaw can be preserved. According to the CBCT, many of his teeth in the anterior area are not in the bony housing anymore. They are only connected with resin to one another. Okay, so this is an interesting baseline. After, of course, we don't go for immediate loading. In this case, it is always submerged healing. And after the healing time has been, after we've been waiting for a healing time of approximately 3 months, we do the uncovering, and then we restore the implants with multi-abutments in order to produce retained restorations. This is the finalized layered anterior restoration. Again, we use 3D Pro in this case, and layered because we need the pink porcelain in the gingival part, and the posterior is a monolithic, no layering. Unfortunately, due to SARS-CoV disease, our patient failed to come to the appointment that we had last week for final placement. So I hope in one of our next presentations I will be able to show the clinical results. But I would like to share the clinical results with this case, which is one of my favorite cases. Again, cross arch, upper and lower, with zirconia monolithic and layered. Fairly young patient, 50 years old. And this is the baseline. Upper jaw completely dentulous, lower jaw terminal dentition. And the cause for this disaster is that he fears extremely dental services. So he totally neglected his oral situation because he had terrible pain during his dental visits in the past. Okay, so this is a clear message also for us that we should respect our patients' feelings and pain. Okay, so our treatment should be as painless as possible. In this case, after discussions and after defining a treatment plan with this patient, we could proceed. He allowed us to proceed for immediate loading protocol because we get appropriate primary stability, 6 implants in the upper jaw and 6 implants in the lower jaw, and this is his natural outcome with a provisional restoration. So this is a composite veneered restoration metal framework and composite veneered excuse me, this is a restoration that will stay in the oral cavity for it depends, 6 months or 1 year or 1.5 years, according to our clinical priorities and the time limitations of our patients. 1 year later, we observe optimal implant integration and beautiful soft tissue maturation. He is cleaning properly. Also in the lower jaw, same results. Now this is the upper jaw finalized. This is the case that I'm presenting for the first time. So you are the first ones that I am sharing this beautiful case with you. This is an extensive case actually, and this is it's a cross arch zirconia restoration on the upper jaw. This is the upper jaw finalized. We have 1 pontic on each side. These are the final pictures. Again, very beautifully mastered by our dental technician here in Thessaloniki. After the cementation of the titanium cylinders, which is a step that can either be done in the lab or intraoral. This is the lower jaw, which is again finalized. Again, we use 3D Pro for this case. We have 1 pontic on the one side, we have 1 pontic on the other side. And this is the final outcome of the lower jaw. And this is the delivery day. So in situ, the upper one and the lower arch. This case represents in a beautiful way the optimal aesthetic and functional outcomes we can achieve when we follow a thorough treatment plan, as Professor Parel said in the beginning. So careful treatment plan, many intermediate steps to define occlusion, to define aesthetics, to define oral hygiene. But if we pay attention and we are meticulous in following these steps, we can achieve optimal aesthetic and functional outcomes like in this young patient. So with 3D ProZir, we can definitely expect optimal aesthetic outcomes. And again, it's a teamwork. So both parts need to work together. The restorative dentist, the surgeon, the dental technician. It is an open community. There is a lot of discussions. We need to involve and include our patient in the treatment plan. But if we do that carefully, that we can expect that we can have predictable aesthetic and functional results. So by closing my presentation, I would like to share some statements with you, like Has Zirconia made a material difference in implant prosthodontics? This article by Dr. Sadowski from California, I would say absolutely yes. So Zirconia has made a material difference in implant prosthodontics. Zirconia, I think, is a versatile material for implant prosthodontic applications, and monolithic zirconia offers enhanced mechanical properties for implant restoration. Long-term multi-center studies are needed to assess success criteria in patient-related outcomes, and some development, according to this article, is needed to optimize aesthetics. I believe that a skilled technician and a beautiful and strong material like 3D Pro can already provide optimized aesthetics. So I would like to thank you very much. Unfortunately, you cannot see me and I cannot see you. I hope we will meet live someday. This is my hometown Thessaloniki. It has a long history of over 2,500 years, and it has also beautiful nightlife. Pictures you see in the lower part of my presentation are before the COVID situation. Now bars are opening little by little, so by the summer I hope we can party a little bit more. Thank you very much for staying with me. I hope you enjoyed some of the cases. I hope you're motivated to try new materials. We all have to stick to a thorough protocol of treating our patients. We need the teamwork, and we need always to use excellent quality materials in order to achieve optimal long-term results. Thank you so much. Thank you. Bye-bye.